All right, welcome to this high-yield explainer for clinical rounds. We're skipping the pleasantries today, guys, because if you're gunning for that top-tier 270-plus score on your boards, you need absolute, unbroken focus. Let's just head straight to the wards.
Okay, here's your first high-stakes clinical scenario. Picture this. A 27-year-old woman walks into your clinic with a 2-centimeter palpable thyroid mass. You check her TSH, and it comes back completely normal. As the primary clinician, what is your absolute next step in her management? You don't have time to second-guess here.
Okay, let's dive into this. Every single palpable thyroid nodule workup strictly begins with a TSH measurement. The algorithm here is rigid for a reason. If that TSH is suppressed, so it's low, you absolutely mandate a radioiodine scan. Why? Well, because hyperfunctioning, or hot nodules, are overwhelmingly benign. They don't immediately need a needle. But in our patient's case, her TSH is normal, and a normal or elevated TSH instantly mandates an ultrasound, followed by a fine needle aspiration, or FNA, biopsy. Basically, you've got to assume a hypofunctioning, cold nodule is malignant until proven otherwise.
Right, so once you actually get that tissue, you need to know exactly what you're looking at. Let's contrast the histologic signatures. Papillary carcinoma, that's the most common one, and thankfully it has the best prognosis. You're hunting for those classic orphan Anii nuclei, those distinct, empty-appearing ones. Plus, you'll see the concentric calcifications we call semomo bodies. On the flip side, medullary carcinoma is a totally different beast. It originates from the parafollicular C cells. This means it actively secretes calcitonin, and you'll see Congo red-positive amyloid deposits.
Now, what's really interesting about this slide is how the microscopic architecture directly dictates our surgical approach. You can literally see the distinct cellular proliferation here. Papillary carcinoma? That spreads through the lymphatics, specifically targeting the cervical nodes. But medullary carcinoma, driven by those C cells, carries a much more dangerous systemic threat, which we'll actually touch on in just a bit. The main takeaway here is that your histologic diagnosis is the exact blueprint for the extent of your surgical resection.
But listen closely, because here is exactly where examiners will try to trap you. We call it the follicular trap. An FNA biopsy strictly cannot distinguish a benign follicular adenoma from a malignant follicular carcinoma. It's just cytologically impossible. Why? Because to prove a follicular malignancy, you absolutely have to observe capsular or vascular invasion. And you just can't see that on a simple cytology smear. You literally have to excise the tissue via a diagnostic lobectomy to make that definitive call. Oh, and remember, unlike papillary cancer, follicular carcinoma spreads hematogenously, so think bone and lung metastases.
Let's apply all this to a rigorous NBME-style vignette. So we have a young, euthyroid woman with a palpable nodule. Look at this matrix of 5 highly competitive choices. Scintigraphy, option A, is just wrong because her TSH isn't low. Now, options B, C, and D suggest observation or levothyroxine therapy. Do not fall for the observation trap. You absolutely cannot blindly observe a new mass in a young patient without definitively ruling out malignancy first. The clinical data strictly forces option E, ultrasonography-guided fine needle aspiration biopsy. It's the only safe, correct path forward.
Module 2, Breast Mass Diagnostic Algorithms, focusing on age and density thresholds. Consider this your next rapid-fire consult on the ward.
So the diagnostic algorithm here really hinges on a strict age and tissue density threshold. If your patient is under 35 years old, their breast tissue is generally going to be pretty dense. Mammography really struggles to penetrate dense tissue effectively, which makes ultrasonography the primary mandated diagnostic tool. However, as patients cross that 35-year threshold, tissue density naturally changes. At that point, mammography takes over as the absolute gold standard for initial imaging.
And this brilliantly illustrates the radiographic differences, which are pretty stark. On the left, the mammogram gives us this macro-level view of architectural distortion and microcalcifications. Those are your key indicators of potential ductal pathologies. But on the right, the ultrasound lets us definitively differentiate a solid, potentially malignant mass from a simple, fluid-filled, totally benign cyst.
But imaging is really only half the battle. Let's talk about the excisional biopsy mandate. Say you have a highly suspicious lesion on physical exam. It's firm, immobile, maybe there are some skin changes, and you do an FNA that comes back negative or non-diagnostic. You do not stop there. FNA actually has a pretty notable false negative rate, simply because the needle might miss the malignant cells altogether. If your clinical suspicion is still high, the standard of care absolutely, strictly demands an open excisional biopsy to resect and examine the entire mass.
Let's isolate a really specific variance you'll see in young women.
fibroadenoma versus Phyllodes tumor. Both of these present as discrete, palpable masses. Now, fibroadenoma is a benign, slow-growing lesion, super common. But a Phyllodes tumor, that's the dangerous mimic. Fun fact, the term phyllodes actually comes from the Greek word for leaf, which perfectly describes its leaf-like stromal papillary projections. It definitely has malignant potential and requires complete surgical excision with wide margins. Interestingly though, because it spreads hematogenously rather than lymphatically, axillary node dissection usually isn't required.
Module 3 Endocrine neoplasia syndrome traps covering MEN1, MEN2A, and MEN2B. Let's move to this next one and see how it builds. Get ready to integrate multiple organ systems because this is where the exams really separate the good from the great.
You absolutely must have the multiple endocrine neoplasia, or M, syndromes exhaustively mapped out in your head. MN1 is all about the P organs, pancreas, pituitary, and parathyroid tumors. Then you have MN2A and 2B, which are driven by mutations in the RET proto-oncogene. Both of these heavily feature medullary thyroid carcinoma and pheochromocytoma. Where they diverge clearly is at the third feature. MN2A includes parathyroid hyperplasia, while MN2B features mucosal neuromas and a marfanoid habitus.
So the crucial point is this preoperative trap. If you diagnose a patient with medullary thyroid carcinoma, you need to instantly think of MEN2. And if they have MEN2, they might just have a silent pheochromocytoma sitting there. You absolutely require a screening test, like urine VMA and metanephrines, to rule out a pheo before you ever send that patient to the OR for a thyroidectomy. If you miss this, the induction of anesthesia could trigger a massive, lethal release of catecholamines, resulting in a severe intraoperative hypertensive crisis. It's literally a matter of life and death.
Take a look at this integrated scenario. We've got a 47-year-old man post-pheochromocytoma resection who's presenting with a new thyroid nodule. Now, the lab matrix might give you a wide spread of options, but your clinical logic should immediately narrow this down to 5 highly competitive biochemical pathways. The real question is, what serum concentration is fundamentally altered here?
Let's break down exactly why the distractors fail here. A prior pheochromocytoma plus a new thyroid nodule strictly screams MN2, which means medullary thyroid carcinoma. Medullary carcinoma secretes calcitonin. Therefore, a primary increase in calcitonin is literally the only correct path. Decreased calcitonin, biochemically backwards. Any shifts in TSH or T3 would falsely suggest primary hyperthyroidism. An isolated increase in calcium points to parathyroid issues, not C cells. And magnesium is just a complete distractor. You've got to target the calcitonin.
Okay, let's conclude with one final, provocative diagnostic trap to leave you sharp. Say you have a patient with asymptomatic hypercalcemia and an inappropriately normal or high PTH. Everyone wants to rush them straight to surgery for primary hyperparathyroidism. But how do you definitively distinguish that from familial hypocalcuric hypercalcemia, or FHH? If you miss FHH, you're going to subject your patient to a completely unnecessary failed neck exploration. No one wants that. The answer lies in relentlessly hunting for the precise biochemical variable, urine calcium levels. Always check the urine calcium before you cut. All right, stay focused, trust your algorithms, and thanks for joining this explainer. I'll see you on the next rounds.